So we're on page 113, chapter 5. We're going to do chapter 5 and 17. So like I said, there's 8 questions from this chapter. So if you guys are looking at page 113, it starts out with tuberculosis. And so you guys know we have 2 tests for tuberculosis. I mean, there's more than that, but there's 2 main tests that you need to know about. One is the skin test, right, which is the MAN2, spelt, like this up here. It's French. Okay. And then there's the acid-fast facsimile test, which is also abbreviated as AFB. This is the one it seemed like a lot of people didn't really know about. You need to know about this one because if I'm suspecting that my patient has tuberculosis now, like it's active tuberculosis, this is my test. The acid-fast is my test for that, okay? The skin test, if my patient had tuberculosis, fought it off, or it's latent, meaning it's kind of like dormant in their body, will their skin test still be positive? Yes. The skin test doesn't tell me that they're having an active tuberculosis outbreak at this point, but the acid-fast test absolutely will. Okay. So if I suspect that my patient has TB, I'm going to lean more towards the acid-fast test, given the choice between the 2. Now, if this was a ClinSim and you're trying to diagnose it, you could get both. There's nothing wrong with that. Both of them would be helpful. But given the choice between the 2, I'd go with the acid-fast, especially if my patient is having these symptoms right here, which are like fever and night sweats, cough, weight loss, coughing up blood. They've been exposed to somebody who has TB. They're from a country where TB is more prevalent. Could be like South America, Central America, Caribbean, Africa, Asia, Eastern Europe, and Russia. Anybody who's come from like pretty much anywhere other than North America and Western Europe, essentially, right? Or anybody who's been exposed to homeless shelters, jails, prisons, nursing homes, anywhere where people are kind of grouped in together in tight quarters and that nutrition and healthcare is not great. IV drug users, people who have weakened immune systems, like people with HIV. These are kind of our big patient population that we're looking out for. So history is going to help us know exposure, symptoms, that kind of thing, okay? If you're looking at the MAN2 test, you're looking at your skin test, how big would the wheel be if it was positive? 10. Yep. Could be raised. They do have an interferon gamma release test, but that's not very used very often. And so, stick with the acid-fast and the MAN2, okay? All right. So then the next thing, if we're flipping over to the next page here, we're looking at skin testing for allergies. And when we're talking about skin testing for allergies in our regard, we're really just using this mostly for asthma. Just a component of helping me diagnose, does this patient have intrinsic or extrinsic asthma? What are the triggers that I might have this person avoid? And then also help me with drugs as well, because if I know it's allergy related, I might go and add in like Singulair or Montelukast, if you guys kind of remember that drug, right? Okay. So that's kind of what I want you to think of. Of course, allergy skin testing is for a lot of things. People can have bronchitis and rhinitis from it, but for asthma is kind of where I want you to use that test, okay? So we're going to go to bronch, and bronch is kind of weird in the book because it's like at the bottom of 114, then there's this big table about something else, and bronch picks back up on 117. So we're going to do a little bit of hopping around here, okay? So we're at the bottom of 114, and let's talk about bronchoscopy. And if you guys remember, when you do a bronch, there's 2 reasons why you might do a bronch. It's either diagnostic or therapeutic, right? It's diagnostic would be like what? Yeah, looking for cancer, trying to figure out like why a person's having reoccurrent like issues with atelectasis or something like that, right? I'm just trying to figure something out. where if I'm doing like therapeutic, I'm actually trying to fix something in the lung, right? And so here's when you should kind of recommend a diagnostic bronch. And so if somebody has like unknown lesions, and so when you see a lesion on an X-ray, do you really know what it is necessarily? No, you just know there's like a circular something, right? We're probably strongly thinking cancer, but we don't know. So we're gonna go ahead and get in there and see what it is and see if it is. So if somebody on X-ray has lesions, we're gonna figure out, are those lesions cancerous? Are they benign? You know, what's the deal there? So we do that. If somebody's having reoccurring issues with atelectasis and infiltrates on the chest X-ray, we don't know what it is. We're gonna go in the bronch and try to figure that out. Is it mucus plugging? Is it like bronchial collapse? Is there some sort of Malaysia issue there? We'll kind of figure that out. Looking at the patency of the upper airway, which is not something that people typically think about too much. But if you ever work in the ER, when you get out into the field, you're going to do this like all the time. And the ears, nose, throat doctor will call you typically to like the little observation area in the ER, and they'll say, I want to take a look-see. And that means go get a pediatric bronch. I want to shove it down somebody's nose and look what's going on in their airway, essentially, okay? You use a pediatric bronch because it's less it's more comfortable, less invasive for somebody, even if it's an adult, because they're not using suction, so they don't need a big bronch, so you go get a pediatric one. And they'll look down in their nose, they'll look in their trachea. We're looking for things like tumors and things of that nature, any kind of inflammation in there. Like vocal cord paralysis is another thing where one vocal cord gets like paralyzed shut. Yeah, or like burns. If somebody has been in a house fire and they have singed nose hairs, you may want to look down in there and see, are there burns in the back of the throat and the trachea? Because if there are, we may need to intubate this person pretty soon before it swells shut, right? Or if somebody was mixing bleach and like ammonia in the bathroom and it made chlorine gas and they inhaled that, we want to look at the type of damage. And so that's just assessing the upper airway there. Yeah, so you never know. I don't know. I got called a bunch of times for that. Like, I mean, one time they called me for this lady who had had throat cancer 4 times, had it removed, never had a full laryngectomy. I had to sit there while the doctor was looking down. It was like, it's back. You have it again, you know, and it's just like, oh, poor lady, you know. So you never know. So we're also going to use a bronch to see why there's hemoptysis. Is there a bleed? Are we having alveolar hemorrhage? Have you guys seen a BAL done where they do the test for alveolar hemorrhage? So essentially, if you guys remember BAL, it's where you take the bronch and you wedge it into the section of the lung. So you're just getting a sample from that section, right? So you put it in the airway till it won't go any further. And a lot of times what they'll do is they'll take big, like 60 ml syringes of saline. You'll push one, pull it back. You'll push another, pull it back through the scope, push another, pull it back, and you'll lay them out. And if it's like getting redder, each syringe, you have alveolar hemorrhage, which means blood is coming across the AC membrane essentially, right? Which is usually caused by like inhaling toxic chemicals. But there's a couple other things that can cause your AC membrane to open up like that. So you may be looking at hemoptysis or something of that nature. If somebody has a weird cough, unilateral wheeze, stridor, we think they may have inhaled a foreign object, we're going to go ahead and look with the bronch. Anytime we want to do cellular washing or biopsies, the things that you would straight up think for diagnostic, for like diagnosing a pathology and cytology issues and sending that off to the lab. And again, we kind of talked about this earlier, but the toxic inhalation or aspiration of something that may cause burning in the lungs and throat. And then to evaluate any problems you might have with like a trach or an ET tube. So that would be diagnostic. That's when I would order a diagnostic bronch for that. So we're gonna go ahead and skip over this table. We'll just come back to this table since we're talking about bronchs right now. And let's just jump over to page 117 and we'll backtrack. So here's where you would order for a diagnostic bronch. So this is, or excuse me, therapeutic bronch for like treating an issue. So if we're having a problem getting an ET tube in, we can intubate with the bronch. Have you guys seen them intubate with the bronch before? Now the new bronchs that are disposable have a nice little rubber stopper at the top of it, and the ET tube like sticks to it, which is really nice. You know, it's usually not like that with like the old black ones. You just kind of stick that on there, intubate with that. It's nice, right? If you need to intubate somebody in a main stem, or you're using like a double lumen ET tube, you have to use a bronch with that. You can't just put the ET tube in there and assume that it's gone into the bronch that you want. And actually, a double lumen ET tube, do you guys know which way it curves? Does it curve right or left? Left. Yeah, even though the right is the first stop and everything tends to go into the right, because of that reason, you want to go down to the left and have a Murphy's eye into the right, essentially, what you're looking for. Okay. So to intubate a main stem for independent lung ventilation, or if you're trying to just get a sputum sample from one lung or the other, they do that surgery. Sometimes they'll call you down, they'll put in a double lumen ET tube, and they'll tell you to get a sputum sample and send it off to the lab. And when you suction with that, because the double lumen is longer than normal, you can't use a sterile hand. You have to get a special sterile hand, one that's like this long, and get your sample that way. Okay. Sometimes the anesthesiologist will call you down for that. And then, you know, removing any kind of like abnormal foreign bodies or tissues. And then right here is just why we would recommend against bronchs. And so I think we talked about this in another chapter, but if your patient can't oxygenate, your patient is going to bleed, your patient has bad obstructive disease, if they have refractory hypoxemia or they're hemodynamically unstable, these are reasons why I would not order a bronch. I think the one that, you know, I talked with you guys last time we did this chapter that you didn't know was maybe the severe obstructive disease. So if somebody has really bad COPD, we really recommend against bronch in that person. Okay. Okay, and then at the bottom of this page is the BAL, which we just kind of talked about a little bit. The BAL is essentially where I just take the bronch, I wedge it in a section. I'm getting samples from a very specific area of the lungs, because if I do just a bronchial washing and I squirt saline down my bronch and I pull it back up, is it coming from just one spot in the lungs? Or is it coming from everywhere? Yeah, if my bronch's just in the airway and I put saline down it and I suck it back up, it's coming from every part of the lung. So if I'm trying to isolate an issue in one part of the lung, I want to do a BAL at that point. So this can help me diagnose like interstitial lung disease. It can help me diagnose if my patient end up with BAP or VAE, alveolar hemorrhage, like we talked about, pulling the syringes and looking to see if they get progressively redder. The only major contraindication here is that you're more likely to even bleed with this with just a normal bronch, so just watch out for bleeding. So if my patient's on blood thinners, I might think twice, right? If their platelet count's low, I'm going to think twice. What's normal platelet count? 150,000 to 400,000. Right. Okay, so now we're going to jump back and backtrack back to page 115. Okay, so this is recommending different types of blood tests on this chart here. So if you look here, you have a patient scenario and the type of test that you would want to recommend. So if you have a patient who is having what seems to be like a normal oxygenation, but there are symptoms of tissue hypoxia, like lactic acid is really high, I would check your hemoglobin. So up here it says, if you have a normal PaO2 and SpO2 with signs of hypoxia, that can happen for sure when your hemoglobin's low. But typically what ends up happening is when your hemoglobin's low, your SpO2 or SaO2 will be normalish, but your PaO2 will be low. Like they won't match each other essentially. Amount of dissolved oxygen won't match how much percentage we have. So you'll end up seeing that quite a bit. So that would also indicate there might be a hemoglobin issue here, you know. That, or if your PaO2 and SpO2 look good, but maybe your lactic acid is high or something of that nature. Or your SvO2 is coming back on the other side really low. Okay. All right. So post-operative patients with a low-grade fever, we're suspecting that they got an infection during the operation, right? Which happens all the time. And so we want to get a white blood cell count. We want to get blood cultures and sensitivities and check for sepsis here. Anytime you cut into somebody, there's a chance that they could get an infection, especially if the wound wasn't taken care of. Really, anytime there's a fever, we're going to want to check white blood cell count. Okay. If a patient is having sudden onset of shortness of breath with dyspnea, hemoptysis, chest pain, tachycardia, which are signs of pulmonary embolism, I want you to do the D-dimer test. D-dimer test, what's normal, or what would tell me there is a clot on D-dimer? Over 500, okay? Now, not to just completely throw you guys off, sometimes in the boards they get weird, and they'll use like micrograms, and it'll be 0.5 will be the measurement for it. Nanograms, yeah. Yeah. Oh, I'm sorry, other way around. It's 500 micrograms or 0.5 nanograms. So a clot would be over 500 micrograms, which, you know, is this weird looking U thing. Okay, that's not an M, sorry, it's like a U with a little line in the front of it. Or over 0.5 nanograms. So don't let it throw you off. That again, that's not milligrams, that's supposed to be micrograms. It's like a U with a weird line. Okay. So don't let that throw you off. If it's ever in point something, you're looking at nanograms. If it's in whole numbers, we're looking at micrograms. Sometimes they're tricky like that. Okay, the next one on the list is a patient who's showing signs of myocardial infarction or ischemia. We're going to want to go ahead and get either creatine kinase or troponin are my big ones. Of course, there's myoglobin, and there's other ones out there, but the boards really like CK and troponin. So you're going to get those. You don't need to memorize what's normal. Usually the boards are real helpful in telling you if it's elevated or what the normal range is. So you don't need to spend time with that. But CK and CKMB are essentially like, you can use those interchangeably, but CKMB is more specific to the heart. It's the myocardial band is what, you know, but either one that they offer. If it says CK anything, you can go ahead and pick that as part of your diagnostic for a heart attack. And if they're elevated, that tells you they've had a heart attack, okay? Obviously, patients with acid-base disturbances get a blood gas. When in doubt, when you need like to assess somebody's oxygenation or CO2, nothing beats a blood gas, right? It's the end all be all for that. If your patient's having like PVCs or other types of cardiac arrhythmias, go ahead and check your electrolytes, right? Especially potassium. So like that simulation that we just did downstairs last week or the week before, if a patient is having potassium issues, they're going to start to have peak T waves. Then it's going to go to a widened QRS, a T and a wide QRS, which looks a lot like a PVC. And then it'll go to VTAC after that. And how do you treat high potassium? Albuterol, at least 10 milligrams, 10 to 20 milligrams. Yeah. All right. Patients on anticoagulation therapy or with uncontrolled bleeding, make sure you check platelet count. We just said what the normal was there. You can also check your PT, your INR, your PTT. So they're going to help you determine if they're on anticoagulants and if those are working properly or not. Yep. Now there's many other treatments for high potassium. If it's low potassium, the treatment's easy. You give potassium, right? Give potassium chloride. Um, if it's high, you can give albuterol, which is most likely what they're going to make you do on the boards. But you can also give like calcium gluconate. You can give insulin. You can give diuretics. You can give high amounts of like sugar, essentially like dextrose or glucose, anything that makes my pee a bunch. All right, one thing I will have you guys add to this table, which is not up here, is if somebody is having like CHF symptoms, they're having like pulmonary edema, fluid overload, and their heart is enlarged. I might see like those curly B lines on the chest x-ray. What blood test do I want to get for that? BNP, right? Yeah, so I would add that to this, just so you guys have it in the book when you're studying the BNP. BNP is one of those things that it's either called brain natriuretic peptide or it's called B-type natriuretic peptide. And so either one is the same thing, it's BNP. Okay. And over what is heart failure? 100. Anything over 100 would indicate heart failure. CHF, we want to get BNP. Anything over 100 equals heart failure. It could indicate right-sided heart failure as well, but typically we're using this to indicate left-sided heart failure. Essentially, all it's telling me is that the cardiac muscle and the ventricle wall is being overstretched. That's really all that's telling me. Okay. Okie dokie. So if we go to the next page here, we're looking at images, like when you would recommend certain types of images. Okay. So chest x-ray is the first one up. So there's many reasons why we get a chest x-ray. Of course, we would get it to try to evaluate symptoms of a respiratory issue. Anytime someone comes in with chest pain and a cough and all this other stuff, we can go ahead and get a chest x-ray at that point and figure out, is it heart related? Is it lung related? We'll also get chest x-rays to see the progression of disease, especially with emphysema and things of that nature. We'll do it to monitor our patients who are on vents, or as you guys have seen now at a clinical, if you're on the vent, they come and get an x-ray like every day, right? Send them up to the board behind them, shoot the x-ray. Every day, we're trying to monitor that because that's part of the weaning process. The chest x-ray has to be getting better in order to wean your patient, right? Or in order to extubate your patient, I should say. Of course, we also use it to confirm placement of ET tubes. We also use it to confirm lines, including your CVP and your pulmonary artery catheter. And then they also use x-rays to look for NG and OG tube placement as well, but that's not so much a chest x-ray as it is like chest abdominal. So that's when you'd get your chest x-ray. Now, neck x-ray in general, there's 3 times I'd get a neck x-ray. And that would be like if my patient inhaled something and I suspected that there was a foreign object in their throat, or I'm suspecting croup or epiglottitis. If it is croup or epiglottitis, it will depend on the type of x-ray that I get. For croup, I want to do an AP from front to back, right? Just straight shot through the neck, and I'm looking for that steeple sign right here. Okay. If I'm suspecting epiglottitis, I want to do the lateral neck, which is from the side, and I'm looking for that like hitchhiker's thumb sign. Okay. And then again, foreign body aspiration in general. Okay. CT scan or a thoracic computed tomography. Bunch of different reasons why we would get this one. But typically when we have weird things on the chest x-ray and we can't figure out exactly what's going on, then we go to the CT scan. That's my next best thing. It's going to give me a better look, and that can help me identify if my patient has like interstitial lung disease or pulmonary fibrosis, pleural effusions, nodules, things of that nature. Then again, we know spiral CT and CT with angiogram is like the best way to diagnose a PE, right? So spiral CT number 1, then a CT with with contrast or angiography, and then the VQ scan. All right, and then any kind of trauma to the organs, this will give you a better look. In there, so like chest contusions after like car accident or something of that nature. MRI is really good for looking at like soft tissues, vascular flow. That's why they do MRIs of the brain a lot when we're having stroke patients. They're also good for looking at like other soft tissues and like connective tissues, like between joints and things like that. And that's why you usually do MRIs for knees before surgery, things of that nature. So MRI is not really something that I think that you'll pick a lot on the boards because it takes so long, and most of the things you're going to be dealing with are emergency things happening inside the lung. MRI is not great for looking at the lung necessarily. And so I don't think you're really going to be picking the MRI that much. Okay. I would only really pick it if there was no other option and I really needed to look at something. But this would probably be my last option. And then you guys know PET scan is for cancers, right? So essentially when you do a PET scan, it'll light up like a red color where the cancer is, looking for hot spots essentially. And so in general, if somebody has something that ends with OMA, you want a PET scan, right? Because cancers always end with OMA, essentially, like lymphoma, and then the many different types of carcinomas, right? Like bronchial carcinoma, tracheal carcinoma, laryngeal carcinoma, things of that nature. So anything that ends with OMA that's a cancer, I'm probably going to do a PET scan. Right? Check that out. Make sure that PET scan kind of tells me has it metastasized and like spread throughout the body. And that's how they stage cancer. Stage 4 means it has spread to like the bones and the brain typically, which is meaning that the treatment is probably not going to work great. Pulmonary angiogram. If you guys remember, this is for pulmonary embolism, essentially. This is where they go in up to the thigh and the femoral artery or through the radial artery, and they squirt dye down your pulmonary arteries and look for occlusions. And just remember that this is my last thing that I'm going to do. And what I mean by that is not that you will do spiral CT, CT with contrast, VQ scan, then this. If you've done one of those other 3 that I just talked about, then you go, and that comes back inconclusive, go to this. So if you did a VQ scan, it's inconclusive, go to this. If you did spiral CT, it's inconclusive, go to this, right? Don't walk down the steps of like best to worst necessarily. Pick one of those 3 first ones that we talked about. If that doesn't work, go to this, diagnose it, okay? A VQ scan is just for pulmonary embolism. It's a perfect, even though it's probably the least helpful, it is a real popular choice on the boards for pulmonary embolism, okay? Transthoracic ultrasound. So typically when you're going to do an ultrasound of the chest, it's for a pericardial effusion, pleural effusion, hemithorax, empyema, or pneumothorax. And so pneumothorax is not really something you guys think about too much with getting an ultrasound, but I have seen board questions pop up where they're like, hey, this is going on with your patient, and they essentially give you the option to either do this, MRI, or CT, and the answer is to do the ultrasound. If somebody had a pneumo, why would you want to do the ultrasound over CT or MRI? It's quicker and it's done at bedside, right? So if you can roll it in, they can look and they see air in there, they can immediately do the needle aspiration or the chest tube right there in the room. No need to take them to CT, read it, bring it back, and do the chest tube at that point, right? So stuff in the pleural space is where I'm thinking ultrasound essentially, and stuff in the pericardium. Like if I was trying to diagnose tamponade, this would be my go-to here. Okay, and then, ultrasound helps with the thoracentesis, so they know where to stick. Have you guys seen that? Anybody seen it? Yeah. we'll try to watch one if a doctor's doing one, just try to stay back and like maybe skip the next vent check and check that out if you can, just so you can see how it's done. But they do ultrasound, they find the space between the ribs, so they're not poking into anything they shouldn't be. And they can identify where the fluid is, and it's gonna give them the best result. And so they always use ultrasound for that. That's of the chest. The other times you'll see ultrasound, obviously, is when they're doing like art lines and things of that nature, and then echocardiogram for heart issues. So, okay, so we can go ahead and skip on over to 118, since we already covered this bronch stuff here. Recommending pulmonary function testing. So again, this is just recommending like when you would do this thing, not necessarily reading it or anything of that nature. So the first one is your peak expiratory flow, or your PEFR, right? This is your peak flow meter. And so when I think peak flow meter, I'm always thinking asthma, essentially. That's not always the case, but I am thinking asthma. So peak flow tells me the muscle tone of patients with asthma. And they use that term on the boards, the muscle tone. So essentially, is there bronchospasm, which is like muscle contraction of the smooth muscle? Tells me the muscle tone over time via diary. Okay, so we know that our asthmatics use peak flow when they do their little documenting every morning. They look at their asthma action plan and they decide if they need to up their medication that day or if they can go on with their normal day. We're also going to use peak flow to see if bronchodilator therapy is working. So if I give a breathing treatment, do peak flow before and after, I would like to see that my peak flow went up after the treatment. If it did, I know the treatment is working. Okay. If I'm seeing a 12% change or more in peak flow, it's just like FEV1 that's telling me that there is reversibility in this patient. In general, I'd like to see it get better even with COPD patient, but if I'm seeing a big change in my peak flow, it's just like FEV1. It's telling me that this does have reversibility. Okay, bedside spirometry, I'm going to skip over that one because really the indication for bedside spirometry is anybody who qualifies for PFTs, but they just want to do it in the room. There's nothing different to it. There's nothing different about reading bedside PFTs or anything like that. They just move the cart up to the room and they do spirometry. Obviously, they can't do body box up there, right? Or nitrogen washout or anything like that, but they can do spirometry like normal. Okay. Pre and post bronchodilator spirometry, either a bedside and lab, doesn't matter. Essentially, this is just confirming the need for like bronchodilators. Okay. It tells me if there is reversibility and if they're going to work or not. And it helps me diagnose asthma as well. Okay. Getting your forced vital capacity is good for diagnosing any type of obstructive lung disease. This also can help with neuromuscular diseases, since we look at vital capacity for neuromuscular diseases as well. And you guys remember MVV is for respiratory muscles, and this tells me respiratory muscle disability. Do we ever do MVV on a neuromuscular patient? No. I mean, that's a respiratory muscle weakness issue though, right? A neuromuscular patient, someone with ALS has respiratory muscle weakness, correct? Right, but yeah, it's essentially, we know they have respiratory muscle weakness, right? It's part of their disease process. All I'm going to do is wear them out. So this is where students kind of get thrown off sometimes with MVV. They're thinking, this is somebody who has weakened respiratory muscles. I need to do MVV. Do not do it on a neuromuscular patient. ALS, Guillain-Barré, myasthenia gravis, any of those, do not do MVV. This is more for COPD patients and patients with interstitial lung disease or pulmonary fibrosis, where you're trying to diagnose how bad is their disease process and how weak are their muscles, essentially, right? What's their degree of debility? Okay, if you're looking at FRC and TLC, which RV kind of falls in this category as well, which are our volumes, especially TLC, we're looking to see if there's a degree of hyperinflation for obstructive diseases, and it tells me if a person has restrictive disease, right? So I want to order volumes in general if I'm trying to look at if there's air trapping or if there is a restrictive lung disease. So TLC will be low with restrictive lung disease, TLC will be high with obstructive disease. Okay. DLCO, I want to go ahead and get that if I'm thinking somebody has a restrictive lung disease, because that can tell me if it's interstitial lung disease or pulmonary fibrosis. Those will cause my DLCO to be low. I'll also use DLCO for being able to diagnose either emphysema or cystic fibrosis, because both have low DLCO, and it helps me determine the difference between asthma, chronic bronchitis, and emphysema, right? So if somebody is just obstructive in general, they could either be asthma, chronic bronchitis, or emphysema, and a low DLCO will tell me for sure that it's emphysema, right? Everybody feel pretty good about that? Everybody feel good about PFT stuff? Other than reading them? If you need help reading them, make sure that you come and see one of us. All of us can kind of help you out enough to the point in which you need to know to pass your boards, okay? All right, if I'm gonna go ahead and do like bronchial provocation or like methacholine challenge or cold air challenge or histamine challenge or whatever, this is essentially just me trying to evaluate hyperreactivity, which is asthma, essentially, right? That's all that's really used for. Because an asthmatic can be normal day to day. And so if they have hyperreactive airways, they may have a normal PFT and that's not telling me anything. And so if I expose them to something, they may have a reaction to that. And then I know that they have asthma, okay? Everybody feel pretty good about those? Okay. Cool. Okay, ABG analysis. We don't really need to get too crazy with this. You guys know what an ABG is for, right? If I need to know oxygenation and ventilation and acid-base balance, boy, there's only one way to do that. ABG, right? Now, do you take into consideration that ABG does not actually tell me the true saturation of hemoglobin. It does not tell me the amount of hemoglobin. It does not tell me the type of hemoglobin, right? All it tells me is the saturation of oxyhemoglobin, okay? If I suspect that there is any other type of hemoglobin floating around, I need to do this guy right here, right? Hemoximeter or co-oximeter, which are the same thing. Terms are used interchangeably. You need to know both. Anytime that I suspect there may be carboxyhemoglobin or methemoglobin, I need to go ahead and get the hemoximeter or co-oximeter, depending on how they phrase it. And just, you know, the number one time I'm thinking co-ox is obviously smoke inhalation carbon monoxide poisoning, right? But also keep in mind that methemoglobin can pop up through various forms of drugs, including inhaled nitric oxide. So you got your baby on INO, you got your ARDS patient on INO, you might want to go ahead and check that methemoglobin every once in a while. If I give a bunch of lidocaine, probably want to check my methemoglobin. If I've given a drug that treats PCP pneumonia, I probably want to check my methemoglobin. If I'm having signs of methemoglobinemia, which is like, how do they present? They are cyanotic, right? They're very like blue, gray, purple-ish color. Now their saturation will be almost exactly at 85. It won't be any higher, it won't be any lower. Now, when I say 85, I'm meaning 83 to 86, right? I'm in 85 range-ish, right? It's not gonna be maybe exactly 85, but it might be 83, 84, 85, 86 in that area. It's mid-80s essentially. So when someone has methemoglobinemia, their saturation will always read 85-ish, okay? Now their saturation could actually be 95 and it just looks like 85, or it could be 75 and it looks like 85. We don't know. Because of essentially what happens with methemoglobin is that the iron in your blood, it oxidizes, which is rust. Essentially, when you oxidize iron, it rusts. So it's like ferrous. And that is causing a weird reflection on the light through the pulse ox, and it always reads 85. So it may be reading erroneously low or high. We don't know. And we need to check that. So you've got a like purple blue looking person and their saturation is 85 and you've given a weird drug to somebody, you can assume that it's probably methemoglobinemia. Yeah. How does it happen?
Yeah.
It's just a reaction to like the drug. As far as like how each one causes methemoglobin, I don't know the details on that one, to be honest with you, but it just has something to do with the way the drug is interacting in the blood, causing an oxidation of the iron in. Yeah. Yes.
And if someone is going through smoke cessation. Or was that another test?
No, so for that, you want to do the exhale carbon monoxide test. So it's like exhale the amount of carbon monoxide. We'll talk, it's actually later on in this chapter. Yeah. Because, yeah, that's carbon monoxide. That's carbon monoxide, right? So it's not necessarily, I mean, it can be like your, it's not necessarily your carbon. You can either read the exhaled CO2, right? Do a PFT and a metabolic cart, or you could look at your carboxyhemoglobin. That might be able to tell you as well. But yeah, below 10 would be like, not necessarily normal, but it would be considered like you could, if it's like a carbon monoxide poisoning, below 10, I can stop giving 100% oxygen at that point. Above 10, I need to continue giving. Yes, yeah. And then essentially like smokers is like somewhere between like 5 and 9-ish, somewhere in that area. Normal person's below 5. You look at a couple different books, it can be slightly different answers, but just remember, carboxyhemoglobin above 10, is that what you're saying, like 10? About that, yeah. So, you know, the way these Lindsay Jones ones work is they'll really focus on kind of one thing a lot in each one of these tests. So you'll take another version of this and it won't say anything about the carboxyhemoglobin, but it may have a bunch of PFTs on it. You know what I mean? So it just depends. Each one is real heavy on, or some of them have like weird sleep stuff, like a bunch of sleep stuff on it. So, yeah.
When we have to use the nothing, is it the end of the installation or
On the INO,
yes?
so I mean, like, are they getting the drug to some inspiration,
Yes.
or I mean, that since it's being applied to the airway, they're kind of getting it on inhalation and exhalation. But really, it's just like breathing in oxygen or something. You're just replacing that with this gas, essentially. But when you want to look for like nitric dioxide NO2, that's like poisonous. I don't know, was it like a certain question or something?
Yeah,
you
there was
answered?
asking us exactly when you use, is it on the end, the inspiration or?
For INO?
Yes, on the end, on the expiration.
I mean, technically, it's applied during the whole airway cycle, so I don't really know what they would be asking there, because you're just.
Talking about, okay, There's only one question on that, so I don't that is exactly including when they use the natural, the nothing.
Yeah, during like a PFT. Was it like during?
Yes.
PFT?
Oh,
Like,
yeah,
like,
yeah, that's for the nitrogen washout, that's for the nitrogen washout, yeah. Yeah, so, I mean, that, essentially, whenever you do nitrogen washout or helium dilution, you want somebody to exhale just the normal resting exhalation, and then breathe that gas in to give you the because you're measuring your FRC below,
Yes.
because that's what's left, if you take a breath in and you breathe out normally, you don't push, what's left in your lungs is your FRC. If they can measure everything other than that, then they can calculate what your total lung volumes are. So what they're doing is they're trying to measure what was left in your lungs other than the FRC. So you want to go to resting exhalation and then breathe the gas in, either helium or 100% oxygen.
So it's a rest and
Resting exhalation. Yeah.
expiration.
Yeah, yes, yeah. Because that's, you know, if we're like right now, we're just breathing, we're not thinking about it. We're breathing out to resting exhalation, and what's left in our lungs is our FRC. And so they're using that to calculate the different volumes essentially. Yeah, that would be the nitrogen washout. Yeah. Okay, so let me see. Where were we at here? Non-invasive. Symmetry, we did that. Okay. Before we move on, is everybody okay so far? So far, so good? Okay. So yeah, co-oximetry, hemoximetry, get with smoke inhalation, carbon dioxide poisoning, methemoglobinemia. Okay. And then yes, if it is above 10, you need to still give 100% oxygen, do not wean oxygen. Once it gets below 10, you can stop weaning oxygen. Hyperbaric chamber. Yeah. Yeah. So on the next page, you have essentially looking at page 120, you have indications for non-invasive monitoring. So you guys know about when you should get ABGs. Really with transcutaneous, I don't really get this with like infants and things like that. You don't use them on humans, on adults, on real humans. Okay, now let's stop and talk about capnography and capnometry. There's a bunch of uses for this. Obviously, we're going to use this to monitor person's exhaled CO2, but we're also going to use it for ET2, right? We know that that's the gold standard. When you intubate somebody, you put the capnography on there, you measure it. If you get a number back on it, you're in the airway, right? If it's 0, you're in the stomach. We'll also use capnography whenever we're doing moderate like sedation, like conscious sedation. So during bronchs or other procedures that may be slightly invasive, but we don't put somebody completely under and intubate them. During mechanical ventilation, especially when that person is having increased ICP. You definitely want to do capnography because if I have someone with increased ICP, I want to make sure that I know that their CO2 is on the low end, correct? Okay. Okay, and then of course, during compression, during CPR. So if I'm doing CPR, what's the minimum amount of end tidal that I'm okay with? 10 is minimum. 20 is preferred. You're really actually supposed to switch out if it's below 20. But I don't know if you guys have seen them use capnography during chest compressions. You've got to have like a big old dude that's like muscular, that's really putting in the work and get above 20. And most of them are going to stay around 15, somewhere around there. But by the book, you need it above 10, you'd like it above 20. It is. It's rare to really see it above 20, and that's why it's kind of like, oh, okay, let me see it on. But yeah, below 10, you got to switch compressors. Just know that. Okay. Okay. And then this kind of section, I don't have anything like highlighted. It's at the top of 120, 121. I don't really have anything highlighted here or anything, but you guys know we've kind of drilled it into you with capnography. If you start seeing that discrepancy in the blood gas and capnography, what are you thinking? PE, right? That's another time that I might want capnography just to kind of monitor that. Because it essentially tells me if there's a giant VQ mismatch. Okay. So I'm gonna go ahead and keep on moving here. Electrocardiogram. Okay, so you should recommend a 12-lead ECG whenever somebody is having heart disease, they're having coronary artery disease, left ventricular hypertrophy, enlarged left ventricle, essentially. Anytime somebody is having chest pain in general, we're going to go ahead and get a 12-lead just to rule out that it might be a heart attack or not. Or anytime that somebody has a weird arrhythmia. The only time I probably wouldn't get a 12-lead is if you suction somebody and they throw a couple PVCs and you put oxygen on and it goes away, don't worry about 12-lead. But any other time, I would go ahead with any weird rhythm, also sinus tach. If it's sinus tach, don't worry about the 12-lead. Sinus tach is normal for most patients who are in pain, anxious, things of that nature. But anything other than sinus tach and a couple PVCs, I want you to get the 12-lead, okay? As far as the boards go, anybody can get a 12 or anybody can get like just the regular ECG. the 5-lead one, nothing wrong with that. But the 12-lead needs to be for when you suspect heart attack, try and rule out stuff for chest pain, or they're having like arrhythmias. Now, if they're throwing 7 PVCs in a minute, by all means, get the 12 lead out, okay? But if they're just throwing a couple here and you know it's hypoxia, don't worry about it. Okay, so here's exhaled carbon monoxide. So this is like the other thing other than carboxyhemoglobin that we're going to talk about here. So this is just something that's done during PFTs. It's your exhaled carbon monoxide, and they use this typically just to see if somebody's still smoking or not. So if you're wanting like a COPD patient to be on the transplant list, they have to prove that they're not smoking cigarettes anymore. They'll do blood tests for nicotine. They'll also do this test right here. That's to tell me if they're still smoking or not. So if they have any kind of reading above 6 to 8 parts per million, it probably means that they're still smoking, if they smoked in the last day or so. Typically, it's going to be like 3 to 4 for somebody who's not smoking. So if it's kind of up there, 6 to 8, somewhere in that range, they're smoking cigarettes. They're lying to you if they tell you they quit smoking.
If they're looking to put someone on the transplant list for that, how often will they do that?
I think they'll usually just do it every once in a while. Like they'll do it just as the workup, and then any like 6-month checkups that they'll do it at. Yeah, especially if you
They could
suspect
just
it.
stop like 48 hours before.
They could.
and then
They absolutely could,
pick
yeah,
back up.
yeah. And they like to do this test because a person can still be doing nicotine patches and their blood work is still gonna come up positive for nicotine, right? And there's nothing wrong with that. Nobody said they couldn't do that, right? They like to do this test as a workup to see if somebody's still smoking. Right, part of smoking cessation, part of like transplantation and things of that nature. Okay, the other exhaled gas that we're looking at is your pheno, your exhaled nitric oxide. Sure. Yeah, so as far as I know, I think just like it could be a little bit higher with inflammatory response diseases, but I've never seen anything on the board on that, so I didn't go into it. Typically, if you're thinking there's an inflammatory response, you're actually gonna go to this guy right here, the pheno. But yeah. So like it says here, if you have like inflammatory with chronic obstructive diseases, which is COPD, maybe even asthma, you could have like endogenous carbon monoxide just through metabolism and things of that nature. So it could be a little bit higher for them for sure. Yeah, but typically if you're looking for inflammatory markers, we're looking more at like pheno. Okay, so pheno can tell me airway inflammation, which can be really helpful, especially in asthmatics. Okay, so I want to go ahead and look at this for asthmatics. Not only is this going to tell me if this person is having inflammatory response with asthma, it's also going to tell me how they respond to steroids. Because what do steroids treat? That's right. So if you look at this table down here, it tells you like what would be like normal for pheno. So essentially for adults, anything like 25 or less would be normal, children 20 or less, right? Anything above 25 or 20 would indicate we're having some sort of inflammatory response. Above 50, we're really having it. But in general, if you just remember adults 25, children 20, anything above that is telling me there is some sort of inflammatory response. So let's say I have a kid, they have asthma, I put them on fluticasone, right? So take fluticasone twice a day. When I first looked at it, let's say that their pheno was like 37. Okay, I put them on the inhaled corticosteroid, which reduces inflammation. What do I expect to happen to that pheno number next time I measure it? Yeah, it should go down, right? It should come more back to this normal range, and that tells me that inflammation has gone down. If it hasn't gone down, the steroids are not working. I need to increase steroids, right? If I've maxed out my steroids, then obviously steroids are just not going to work for this kid. We need to find something else.
Did you go to increase them first, or would you?
I would increase them first, especially with asthma. The way you kind of do asthma is you start with steroids and then you double the dose, and you can even triple it because usually steroids have a low, medium, high dose, depending on the drug. But you want to go up on your steroids first, and if they still have symptoms, or they're still having pheno, or they're still using their inhaler, then go to like a long-acting beta agonist, like formoterol or formoterol, something of that nature, right? Or maybe switch them to Brio or something like that. Which is the opposite of COPD, right? COPD, you would do steroids kind of more last. Asthma, do steroids first. It's really effective for them, and just double it. And if that doesn't work, then add in your long-acting beta agonist. Does that make sense? So in general, the pheno will tell me if they're having inflammatory issues, and it really is a big indicator for asthma in general. So if they told you this patient's pheno was 35 or something like that, then you would know, oh, this person probably has asthma, right? And on top of that, if they're getting steroids, I would expect for my pheno to go down. Okay. So that chart's kind of helpful there. The next thing that we're going to kind of look at under non-invasive monitoring is overnight pulse oximetry, which is on page 123. And so essentially there's two main times I want you to do overnight pulse oximetry, and that's when you suspect sleep apnea or a COPD patient who is being hypoxic at night. Those are the two. And those things live independent of each other, because the COPD patient might just become hypoxic at night due to their disease process and have no obstructive disease. Both of these diseases would fall under that. So this kind of breaks it down into three different sections, but in general, if you look at it, it's just identifying sleep apnea. Either it'd be like obesity, hypoventilation, or just hypopnea or whatever, and then their need for CPAP, or just patients with COPD at night. So those are the two times once you order overnight pulse ox, is if you want to try to diagnose sleep apnea or COPD patient you suspect is becoming hypoxic at night. So if I had a patient who's borderline on their oxygen and their COPD, and I ran them through the whole gambit on a simulation, and I'm trying to send them home with everything that I want to send them home with, if their oxygen is borderline, maybe their PaO2 is like 55, like right on the line for getting oxygen, I probably want to do an overnight pulse ox study, because if they're barely making it during the day, they're probably being hypoxic at night. So this might be part of the thing that ordered this 6-minute walk test, pulmonary rehab, the whole thing, right? Room air ABG, all that stuff is what I'm going to order for this guy or gal. Okay. Then moving down here, polysomnography is the #1 way to diagnose sleep apnea, right? This is the end all be all when it comes to diagnosing sleep apnea. So if you have a patient who has sleep apnea symptoms, which would be like you got headaches, they're tired, they fall asleep randomly, daytime sleepiness, pulmonary hypertension, polycythemia, but mostly it's like snoring at night, sleepiness during the day, and just like falling asleep and having headaches throughout the day. That's indication for people are looking around like, oh God, I have sleep apnea.
So, there's not an age yet.
There's not, no. No, there's not an age yet.
My friend, back here, and I literally just set him up on an appointment, and I heard this that how he's gonna.
Yeah,
Going to be a-
yeah.
I just make sure there's no age. So that's what we can-
There is no age. What's that? Probably, yeah. Oh my God, I went on like, my younger brother's like bachelor party, went to New Orleans, and this dude came that was like their buddy, and like he snored so, I mean, I've never heard anybody snore this loud. And I mean, it was just like, it kept the whole Airbnb like up, you know, and like you could hear him stop breathing at night. And I kept telling him like, dude, you got sleep apnea. You got to get that taken care of. And he was like, yeah, whatever. And then like 3 months later, he fell asleep while driving his car and like wrecked into a pole. He was okay, but now he's on a CPAP. That's all it took. All it took was him falling asleep at the wheel. But it's really bad on your cardiovascular system. That's the problem, is if you're having hypoxia at night, it's causing pulmonary hypertension, which is starting to cause like right-sided heart failure, unfortunately. So it's really hard on your heart. The heart needs a lot of oxygen. Yeah. So again, like morning headaches, snoring, falling asleep during the day, excessive daytime sleepiness, and apnea, obviously apneic issues at night. So, when you look at your overnight pulse ox study, if it's bad enough, they won't even do the sleep study. They'll just give you a CPAP. If it's kind of borderline, they're going to do the sleep study for sure. And my brother showed me his sleep study, and he had like 80 some disturbances in an hour, like sleep disturbances. And I was like, oh yeah. 84, I think he had. Yeah. So. Okay. The last thing we're going to look at here, other than just a real quick thing about thoracentesis, is on page 124. And so this is indication and contraindication for indwelling catheters. So like, why would you order these catheters for somebody? And the first one is an arterial line. So really just two reasons why you do an art line. One is to monitor somebody's hemodynamic pressures because they're on vasopressors. They're on Levophed, dopamine, epinephrine, phenylephrine, something like that, is trying to get their blood pressure up. We want to monitor that, so they're going to need our line for that, or somebody who's needing frequent APGs. Those are kind of like your two, really the only reasons why you would order an art line. Okay, monitor blood pressure because of blood pressure medication and APGs. Okay, a CVP, which is a central line. There's a lot of reasons why you would go ahead and order that. So CVP tells me what about fluid balance? Yeah, it's above 6, hypervolemic, below like 2, I'm probably dehydrated. So it kind of tells me essentially a fluid balance and can help me with fluid resuscitation. It does tell me what's kind of going on the right side of the heart a little bit. It can also help me give drugs. You guys know central line is the best way to give drugs to people. So if somebody needs Levophed or like real strong antibiotics, a lot of times they'll do a central line or a PICC line to give that to them. Or chemotherapy, but that's usually through a PICC line. And then to perform plasmapheresis or hemodialysis, that's usually a PICC line, or excuse me, the central line as well. Central line can either be in the IJ or subclavian down here. That's when I would get my CVP, is to monitor fluid balance, give drugs, do dialysis. Pulmonary artery catheter. This can tell me all types of stuff. Tell me if my patient has pulmonary hypertension. Obviously, that's kind of the main thing, is pulmonary hypertension. It can help me identify the cause of pulmonary edema. So if I see that a person has bilateral fluffy infiltrates, I'm thinking they have pulmonary edema or they have ARDS, right? And so let's say I look and my PAP is like 45/30, okay? And my wedge is 15. What would you guys think? Left heart or lung? So PAP like 40/30s, wedge 15. It is lung. It is lung related, because even though wedge is, yeah, so what is normal wedge? 412, right? Anything less than 18 does not indicate heart failure on the wedge. So I would say it's ARDS, right? If my wedge was above 18, I would say it's left-sided heart failure, it's pulmonary edema. 18 as far as I know.
Until 17.
Yeah, so,
Yeah, it's like that was maybe greater than 17.
okay, yeah, you know, what's 1 centimeter of water pressure between friends? You know? Okay. So, you know, they're not gonna be that bad on the boards and make you split it like that. They're usually gonna give you a normalish wedge and then you're gonna say ARDS, or they're gonna give you a really high wedge and you're gonna say cardiogenic pulmonary edema, right? Okay, so they won't split it like that. So I wouldn't sweat the small stuff when it comes to that, okay? Okay, moving on. Actually, did I cover all these? Okay. Oh, yeah, so we did identify the cause of pulmonary edema, and ARDS is the heart, pulmonary hypertension, hemodynamic responses to therapies, and this would mostly be if I was giving them Velitree, I would like to see my pulmonary artery pressure down. Typically, I'd like my normal map is like 10 to 20 on pulmonary artery pressure. If you're giving Velitree, you need it below 30 typically, and that's how you wean your Velitree or Flolan or whatever it is that they're using these days. And then to identify the causes of various types of shock. So what that means is there's really only one place to get a true mixed venous gas, correct? And that is where? The distal port of a pulmonary artery catheter, right? And so a true mixed venous gas tells me true PVO2, true SVO2. Okay, and so that right there tells me what type of shock I may be having. My SVO2 is lower than it should be. I'm in like cardiogenic shock. Okay, like my tissues are picking up too much oxygen because my cardiac output sucks. If my SVO2 is erroneously high, I'm in septic shock because I've now lost the ability to pick up oxygen at the tissue level. Okay, due to a loss of systemic vascular resistance down here. Okay, so they use this to monitor like sepsis and cardiogenic shock. Yes. At the distal port of the pulmonary artery catheter, which is the very, very tippy end, past the little wedge balloon. So essentially, when you're drawing venous gas from somebody, if I drew a VBG from my arm and a VBG from my leg, we're gonna be pretty close, right? But they're gonna be slightly different because they've been different places. They've dropped off and they picked up stuff from different areas of the body. But when I grab blood from the pulmonary artery, right before it enters the lungs, it's blood that's been mixed from everywhere, right? It's just like a big churning factory of blood from arms and legs and head and everything. And so it's the most mixed, accurate venous gas, essentially, okay? And so true mixed venous gas tells me tissue oxygenation, essentially, right? Because SVO2 tells me how well are my tissues picking up oxygen. Low SVO2, my tissues are really picking it up. High SVO2, my tissues cannot pick it up, okay? That'd be cyanide poisoning or septic shock or something of that nature. Yes, yes. So low SVO2 means the blood is over depleted, right? It's giving up more oxygen than it typically would, meaning my cardiac output is low. That's what I would indicate with that. Low SVO2 equals low cardiac output. High SVO2 is telling me septic shock or cyanide poisoning, typically. Something's telling me like tissues cannot pick up the oxygen for whatever reason, which is typically septic shock. Right? So that's what it means by various shock states, right? So low SVO2 would tell me cardiogenic shock, high SVO2 would tell me septic shock.
So hypoxia has low SVO2. That's because they're grabbing a lot.
Yeah. And it tells me there's low cardiac output. So it's telling me is that the tissues have the ability to grab the oxygen, there's just not enough blood flow. Yeah. So if my left side, if I go into cardiogenic shock and my left heart fails, and I'm only putting out 2 liters in a minute when I should be putting out 5, my tissues are like greedy, the hungry little guys, right? They're just like grabbing it. So it comes back lower than 75%. But if I'm in septic shock, I've lost the ability to perfuse these areas. And so Now the SpO2 is coming back higher than 75, right? Because I've lost all systemic vascular resistance out here. I can't perfuse my leg muscles, arm muscles, everything's being shunted to the organs. So it comes back not used, essentially. You know, how crazy the boards will be with this, I don't know, but if you go and take your ACCS, these are the kind of things you need to know. I mean, they will ask you a couple questions about this on the boards, but I mean, if you're just like, ugh, whatever, then it's not the end of the world. You're gonna be okay. If you know your other core respiratory stuff, okay? Okay, and then the last thing on this chapter is thoracentesis. So when would you order thoracentesis? Essentially, you order thoracentesis to drain fluid or to diagnostically get fluid to see if there's cancer, bacteria, whatever inside that pleural fluid, right? So it's either therapeutic to drain off a pleural effusion, or it's diagnostic to see if there's cancer or an infection in the pleural space. Okay, so those are the two times that I want you to do. Right? Just also keep in mind that, like it says right here, a therapeutic one, which would be for draining fluid off of pleural effusion, you only need to drain pleural effusions if they're causing respiratory distress. Somebody has bilateral pleural effusions, but they're not breathing, 40 times a minute and looking bad, don't worry about it. Just leave them. The body will reabsorb that eventually. But if they are breathing, 40 times a minute and their oxygenation doesn't look good, by all means, go ahead and do thoracentesis and drain that fluid. All right, let's go ahead and take our break and we'll come back at 1:35. Yeah, sure.